right, thanks everyone for joining us. We'll start our webinar momentarily. We're talking about clinically integrated networks, realizing their real value. And I'm Lisa Towers, Director of Marketing for Lumina Health Partners. Next slide, please. A couple of housekeeping items as we run through the webinar. It will be about 30 minutes of presentation time and then 15 minutes of Q&A. All participants will be muted during the webinar, but you can use the chat feature in your toolbar if there is a question that you would like to ask. You can also formally submit a question to our Q&A box in the Zoom control panel. You can see the arrow pointing to the Q&A section there, where you can submit any questions at any time. You don't have to wait until the end of the webinar. And then we will ask those questions at the end. The presentation that you will see today will be emailed to all participants after the webinar. And we also invite you to join our next monthly webinar, HCC's A Key to Value-Based Payments, on February 21st. Hope to see you there. Next slide. We're Lumina Health Partners. We're your partner on the journey to value. We work with recognized industry leaders, hand in hand with clients, to help guide healthcare organizations as they optimize the performance of programs to meet the demands of an increasingly value-based care payment environment. Next slide. And these are our advisory services, which you may be familiar with some of these: value-based strategy, digital innovation and analytics, clinical transformation, leadership and governance. And today our webinar topic falls under value-based strategy. Next slide. Today we'll be talking with Lynda Mischel, who's Managing Principal for Lumina Health Partners. She specializes in helping clients develop and execute strategies to optimize operational and financial performance in population health, clinical integration, physician organizations, delivery systems, and leadership development. And also John Marren, founding partner of Hogan Marren Babbo Rose. He has been in the industry with 10 years of clinical and administrative and healthcare, with more than 35 years of experience in healthcare and general corporate, not-for-profit and transactional law, and he is recognized as a national expert in managed care, clinical integration, accountable care organization development, and other hospital and physician alignment strategies. So welcome to both of you. Next slide, please. And Lynda, I'll turn it over to you to cover our agenda.
Great. Thanks, Lisa, and thanks to all of you for attending our webinar today. Over the next 30 minutes or so, we're going to talk about how clinical integration continues to be an essential strategy as you grow your organizations and move into risk-based contracts. We're going to look at how to optimize operations and analytics in these new contracts and new organizations, how to form effective networks through contracting and partnerships as you may be thinking about expanding your CIN or ACO with physicians, as well as acute care and post-acute care partners. And finally, we're going to talk about making sure that your CIN or ACO meets legal requirements as well as it continues to be in compliance. We are all continuing to struggle in the complex and challenging healthcare delivery system as we continue to change the delivery system and discuss how best to improve quality and reduce costs across the system. Many of our institutions are working on many strategies simultaneously to affect these changes, mergers and acquisitions, multiple payment strategies like bundled payments and ACOs, working in clinically integrated networks, as well as implementing technologies across the system, both in system implementation as well as new technologies that are becoming more and more available to us to help our high-risk patients become more compliant in their healthcare plan. Value-based opportunities continue to grow and are going to continue to grow over the next few years. Many of you have probably seen the final CMS MSSP rule or the ACO rule called Pathways to Success, which is going to force ACO participants in moving closer and closer to risk-based contracts over the next 24 months. As we know, as Medicare goes, do commercial payers, as well. So we believe that we are going to see a rush to more risk-based kinds of payments and contracts with commercial payers over the next few years. So as we think about the continuum from fee-for-service to global payments, it's a good time to begin to think about where your organization fits in this continuum over time, and think about how you are preparing to move from wherever you are on the value-based payment strategy now to a global payment or a risk-based payment. The forces that are driving change continue to be similar over the next few years, although I think we're going to spend a lot more time thinking about locations of care and driving our patient population through ambulatory and post-acute care in a more timely and effective way. We need to be thinking about physician relationships, not only in our primary market, but secondary market. We're going to talk a little bit more about that further in the presentation, but making sure our physician relationships are strong, whether they're with employed physicians or with independent physicians, and think about how to align our strategies with physicians over time. We need to continue to think about different payment models and how that's going to work in our institution, whether you are in a large physician organization or a health system. We also need to think about how we're going to innovate in technology, both in systems and in the multiple new products coming on the market in wearables and other digital technologies to support patient populations. As we enter risk, however, we are going to need to begin to think about patient demand and demographics a little differently, in that our patient populations are going to need to be large enough to spread risk across a benefit structure. And while thinking about that, we're going to need to rethink our competition strategies in order to grow market share, as well as industry consolidation strategies, so that, as I said earlier, we have a network that really supports the goals of a risk-based strategy, but also a population large enough to bear a risk strategy. In optimizing data, we need to think about all of the different analytics platforms that are available to us across our network and delivery system, and make sure those platforms are really delivering information that is actionable to all of the pillars in our institutions. Importantly, we need to make sure that the data that we're getting to improve efficiency in our operations allows us to do that across the continuum of care, for example, allowing us to continue to improve efficiency in a hospital, but really not helping our post-acute partners or our ambulatory physician partners in caring for those patients coming out of hospitals earlier and earlier is going to backfire on a long-term risk-based strategy. We also need our systems to be able to identify high-risk, low-compliance populations more effectively than we've done before. We have historically been identifying these folks on a person-by-person basis and working with primary care physicians to try to improve the compliance of a health strategy for this population. But we are going to need to look at this population in larger groups along the continuum of the healthcare delivery system to try to get more and more of these folks into a compliance status in their health plan. And finally, we need to make sure that all of our data systems are prepared to manage total cost of care across the network and continuum of care. In terms of our networks, we've been thinking about our networks in clinically integrated networks for a long time, mostly in our primary markets and mostly as it relates to our physician partners. But as we expand our footprint and think about risk-based contracts in the future, we really need to begin to think about how our clinical relationships and who we want to have clinical relationships with across both primary and secondary markets to assure that we can deliver a broad-based population of care. We need to think about operational relationships as well, so that all of our stakeholders have access to good information and good strategies to become more and more efficient across the delivery system. And finally, we really need to work with providers across the network to align our incentives and make sure that everyone who is participating in risk-based contracts has the opportunity to participate in incentives. When we think about risk-based contracts and bearing more risk in clinical integration and ACOs, for me, one of the first things comes to mind is, what are our physicians ready for? And how have we trained our physician leaders to manage in a risk-based organization? Are our physicians really prepared to drive performance in their practices as well as in their clinical programs? Have we educated physicians and physician leaders on how to manage risk-based strategies and how to measure risk-based strategies across their clinical programs? And of course, importantly, as we move into new kinds of contracts, how are we aligning our incentives across both primary care and specialty care? Historically, many clinically integrated networks, and certainly ACOs, have concentrated their incentive programs with primary care organizations. So we need to make sure that we are developing incentive programs for our specialists as well, to make sure that we can reach the goals for risk-based contracts. Clinical redesign is also very important as we begin to think about how to move forward in risk-based contracts. For many of our organizations, we've spent a lot of time working through issues of leakage, as well as developing metrics and managing performance against metrics for our clinically integrated networks. And we are the next phase of trying to understand how to improve quality and reduce cost is really the reduction in clinical variation across clinical programs. So if your organization is thinking about clinical redesign, we want you to think about several things as you are developing a plan for clinical redesign. We want you to think about whether you and your organization have critically evaluated clinical variation. Have you designed incentives to move patients out of hospitals into ambulatory service sites as quickly and efficiently as possible? Do you have performance measures that are based on evidence-based protocols? And finally, as we discussed a little earlier, are your physician leaders equipped to lead this initiative? In terms of contracting with higher risk-based agreements, there are a few things here that are very important to think about as well. As we talked about before, we want to make sure a risk-based contract has a critical mass of beneficiaries in order to spread the risk across a larger group. We want to make sure that all of the parties in the contract are accountable for performance. So that includes the contracting entity, the physicians and providers across the contract, the payer, of course, and even employers as we move into commercial programs. We want to make sure that incentive methodologies reflect the risk portfolio that you've agreed to, and that you've been able to communicate all of the risk-based requirements to stakeholders across the network. And finally, we need to make sure that your organization has appropriate capital reserves to cover any negative performance if that should happen. I'm going to turn our webinar over to John at this point, and he's going to talk about clinical integration structures as well as compliance and multi-market clinical integration as well. John?
Good afternoon, depending on where you are. If you so if you go to the next slide, just a little bit about what we're all about. This is a whole listing of everything we did with respect to the Advocate program. Advocate was investigated by the Federal Trade Commission, sued by United and completed arbitration for about $250 million, investigated by the Attorney General, sued by Blue Cross in federal court when they launched their program. We had helped them develop the program. They were pretty much uncharted waters back then, but as you go through this, you'll read that we won on all those cases. One of the things we did after that was to go back to the Federal Trade Commission and to sit down with them and sort of go over how we saw clinical integration programs, how they could be built. And one of the things they said to us was, okay, that's all well and good, but why would doctors do this? And our answer was because they get to collectively negotiate and get value-based contracts. And so now in over 200 instances, we've accomplished that goal. We took the first 30 projects to the FTC for an informal meeting, just to sit down and say, hey, what do you think? And in each case, they said, yeah, this is pretty good. And towards the end of the stint, and by that I mean they, at one point in time, they just said, stop coming, unless you have something brand new to tell us. But you're showing us the same program over and over again, and we can't represent the FTC in these meetings. But as lawyers who work for the FTC, our attitude is that we would not go after these programs. They're not low-hanging fruit. They look solid. And we had doctors presenting what the program was all about. So what does that mean? If you go to the next slide, what that means is, if you look in the upper left-hand corner, that's a 1996 pronouncement by the Federal Trade Commission where they first introduced the concept of clinical integration. We had financial integration, meaning taking risk and sharing risk, and the FTC was public about saying that's okay. You can collectively negotiate. You're sharing risk. You're financially integrated. There's no motivation whatsoever to arbitrarily increase cost and price. So they came out with that. They also did another weird thing that was to introduce the messenger model that said, well, if you just sent the numbers out to doctors and they checked in or off or did it some other way where there was no negotiation, that's okay too. The problem is lots of IPAs, I mean a lot of IPAs, most, actually started negotiation. Somebody would say, okay, I'm looking at your fee schedule. You're never going to get the pathologist. You're never going to get the, whoever in there with that. And then someone would say, okay, well, what is it going to take? And that became a negotiation. So that kind of launched the FTC investigation of a lot of different IPAs and PHOs. And it gave them the reputation for being anti-clinical integration because a lot of those IPAs claimed they were clinically integrated and none of them were. Okay, so the reality is the program that they identified in 1996, they've now represented with advisory opinions, policy statements, and enforcement actions. And in each case, they've said the same exact thing. And I'll get into that in a minute. But if you especially go to the dose of competition, the lower left-hand quadrant of this screen, what you'll see is there's about 52 different references to clinical integration with a lot of details. So we use this as a roadmap to work with the FTC to develop how we're all going to look at clinical integration. And what does that mean? The next slide, please. Okay, my favorite slide ever, underlined in red in the middle, an active and ongoing program to evaluate and modify practice patterns by the network's physician participants and create a high degree of interdependence and cooperation among the physicians to control costs and ensure quality. That's the key right there. So it's an active and ongoing program, and it continually grows and evolves. We have if you look at the Advocate Value Report, and I'm referencing them just because they're the oldest, we did that in about 2000, I believe, or 1999. So if you look at their value report, they will tell you what kind of value they have, and they don't get into a lot of how they do it, but there's a lot of information about that. So peeling it another layer off, we go to the next slide. What you need is a network of physicians willing to demonstrate a high degree of interdependence and cooperation. So you need a network of physicians. So in building a clinically integrated network, which we do now the same way we did it in 2000, 2001, 2004, whatever, is to get a leadership group of physicians together and then beginning to educate other physicians about what is clinical integration. Heartfelt in this is a program of initiatives and metrics. Remember, it's practice patterns. So we have to have the docs following practice patterns. And not some of the docs, all of the docs, all the physicians in the network, to control costs and ensure quality, which, as Lynda mentioned, is supported by an infrastructure that allows physicians to evaluate and modify practice patterns. And this is the sticking point in a lot of network development. Many of you who are on this phone might have run into this issue themselves, is where do I get this infrastructure? I have doctors who are on a lot of different EMRs or no EMRs. I've got a hospital that's got a lot of data, but I needed to get it out of there as well for people who practice in the hospital. So I need to have a system that works. So one of the things that Lumina does is to work on developing that kind of infrastructure process, because you have to be able to measure physicians' performance. I can tell you in the old days at Advocate, it was going through medical records by hand. So, or looking at papers, or looking at, claims reports, things like that. And you need an identified payer strategy. And the reason you need the payer strategy is when we started doing this, a lot of doctors would say to us, well, shouldn't we run it for a while and make sure it works and we're getting the quality? And the answer to that is no. One of the cornerstones of clinical integration, according to the FTC Bible, is very much, contracting has to be reasonably necessary to ensure participation in the program. If you get a clinical integration program to work successfully for a couple of years, you've proven that you don't need to collectively negotiate if you haven't negotiated a contract. Okay. The other thing is you need to get incentives into the network. One of my defenses of the Advocate way back when was, look, in 2005 and earlier, MedPAC had identified the need to, Medicare Payment Advisory Commission, by the way, had identified the need to provide incentives to physicians. They said, get physicians to work together to fix healthcare, get physicians to follow metrics and benchmarks, get physicians to have data on those efforts, and pay them a financial incentive. So throughout the history of how do we work on healthcare is the idea that you got to have data and you got to have a strategy that gets incentives back to physicians. Next one, please. Okay, so going back to the old days. In the old days, and still sometimes now, a typical clinical integration business structure had a health system after it worked with the physicians and people like us and Lumina to develop a network and develop the concepts and the metrics and all of that stuff, form an organization, typically an LLC, wholly owned by the hospital. We have advocated consistently for having a wholly owned entity so that the hospital, which may or may not be a 501c3, has more flexibility in terms of funding the operation. If you're a 501c3, and there's tons of literature published by the IRS over the last 20 years that says any joint venture has to be 50-50. If the docs are going to own half, they got to put in half of the money. And when you start going to physicians and asking for money that they'll never see back, because these entities don't retain earnings, they're not going to throw up any dividends. They're going to pay money out in terms of incentives. It makes no sense. It also means I have a 50-50 board. In this model, I can have more physicians on the board than I can hospital folks. Hospital protects itself through reserve powers, so the organization can't go off the rails. You look at the left side of the slide, there's contracts with physicians. All of this is developed through a process that I'll talk about in a minute. And then you're contracting with payers. So it's a single entity here, one medical staff, kind of a closed-knit kind of thing. That doesn't happen anymore. If we go to the next slide, what you'll see is that what we have now, and this is a very small representation. How much can you get on a page? And we have statewide, we have multi-state, we have regional networks owned by hospitals that are not under the same ownership structure themselves. They're separate and independent hospitals, health systems, universities, community hospitals, whatever. And then we set up local chapters over on the left. And the local chapter has the responsibility of working with the local docs, but the quality infrastructure and all the other infrastructure is held at the clinically integrated network. So that I'm in a local chapter. Maybe there's a local school board. I'm in Topeka, Kansas, and the mothership is in somewhere else, and I have a chance to do a contract with them. The local chapter brings that opportunity back to the central organization, and because the central organization is going to provide the operational support, but the face of the network is really with the local chapter and the school board. So it's localized, but it's centralized at the same time. Obviously, the same role is to sign contracts with payers. We're getting many more, and this could be a subject for another webinar, but a lot of people that we're working with around the country are doing much more direct contracting with employers. And that is an interesting species unto itself. But it's getting huge because a lot of larger payers are selecting very limited networks for various kinds of things. Walmart going to Mayo and only a couple other places for transplants or spine surgeries or things like that is a perfect example, but there's a lot more, and even more local employers. So next slide, please. Okay, so this is just an encapsulation or an opportunity for me to talk about what we all do, what we in Lumina do, and that and others are doing the same thing. But the reality is that you get a network of physicians together, or a leadership group of physicians together. You do an assessment, make sure the physicians and the health system leadership are on a good track with respect to each other and what they're about to do. Because I tell hospital folks all the time, this isn't a one-off thing. This isn't building a surgery center. This is your overall tactical strategy, is to focus on quality and to market quality, working closely with physicians. Value-based contracting is a whole new ballgame. So the reality is that you get your starting group and you begin to work on various policies for what does it mean to participate, what does it mean to be on the board, what kind of technology do we need, what's the quality committee going to look like, all these kinds of things, and you build out the organization. Ultimately, you get to the governing piece and the structure and all of that. Ultimately, you form the organization and have a meeting of the directors, and you really launch the program. But the idea in all of this is that it's a process. This is a process that used to take us 18 months. I think it's like 9 months maybe now, just typically because of trying to get meetings organized and things like that. But you go through, you have an agenda for each meeting, you do everything in a very organized fashion, and pretty soon the physicians become spokespeople. The other thing to mention about this is when I was talking about the multi-regional, we now have clinically integrated networks that are linking up with other clinically integrated networks to share ideas, share resources, do things like that, or introduce each other to possible contracting opportunities. Typically, these organizations don't, you have one clinically integrated organization here and one here. They're not clinically integrated with respect to each other, so if they're competing at all, that would be price fixing if they collectively negotiated. But I can introduce you to an opportunity and I can say, all right, I'm over here in Louisiana, but I have this other network in Mississippi that we work with that can help you along the Gulf Coast because you've got patients in both, or insurance in both areas. So That's just an add-on to what I was talking about before. But the process you go through educates the doctors, gets them on board, educates the medical staff or medical staffs as a whole, and we go from there. So I think I'll turn it back to you, Lynda.
Great, thanks, John. I appreciate your information. In summary, we just wanted to make sure that we've covered and answered questions about how CINs and ACOs are going to be essential as you are transitioning to more and more risk in your value-based programs. Medicare and commercial payers are increasingly including risk models, and so we want to make sure that we're helping you understand what those risk models mean and are preparing your organizations to be successful under them. Again, working through current contracts and operations in order to optimize the contracts that you're thinking about and making sure that you are in compliance across your CINs as you're thinking about super or multi-market CINs as well. We appreciate your time, and I'm going to turn it back over to Lisa in case you have any questions you'd like us to answer.
Great. Thanks, Lynda. Can you send it to the next slide, please?
Sure.
You can submit your questions right now through the Q&A function, and I will start reading those off for our panelists to answer. Our first question is, how do I stop leakage in my network?
Yeah, so that's a great question. For many organizations, leakage is a big problem across not only your network, but in your contracts as well. And of course, the better your network performs, the more likely that you're going to get good performance and quality metrics and cost reduction as well. So some of the strategies that we recommend to folks when they're thinking about how to reduce leakage in your network is, of course, data information strategy that allows physicians to connect to each other and easily make referrals to each other across the network. Also, that allows physicians to understand really who is in your network and how to access them. Another strategy is to make sure that your incentives are aligned in when developing contracts in your clinically integrated network.
And John, did you want to add anything?
Yeah. What I would add is that we have years ago people didn't, require physicians to make in-network referrals, obviously when medically appropriate, and that's changing. And the thing that I would say is, yes, you can do it. I would also say you should do it because remember when you contract with a payer for a value-based contract, you're trying to deliver value to them. You promise to deliver value to them. You're also promised your physician members that there could be some incentives for them. So the more value you can drive, the more incentives you can get. So yeah, tightening up your network is appropriate. You can do that contractually or by policy, just as long as it's promulgated and the board supports it and everybody understands it. The thing that I would tell you is when you start working referrals and the location of referrals into an incentive package, you just have to be careful because you don't want to fall into, and you can just talk to somebody about this, you don't want to fall into being accused of paying for the volume or value of referrals, because in-network referrals also refers to the hospital too. So you can do it. I'm not saying you can't do it. I'm just saying you just have to be careful about how you do it.
Great. And at what point can you take an independent physician-led CIN to market for contracting after participation agreements are signed and data connectivity is in place?
I'll take a first shot at that. What we say is you can go if you have something under the hood. Now, what's something under the hood? Well, the comment about having participation agreements entered into is key. Having a quality program in place, and let me fudge a little on the connectivity. Connectivity happens very slowly. So if I've got what we've ended up telling people is, you can go to market before you have everybody connected, so long as you have some people connected and you've communicated, you have a work plan, and a schedule for connectivity, okay? Because you're always going to be adding people to your network, and there's always going to be a connectivity issue. And I can't speak for the Federal Trade Commission, but I know they're well aware of the fact that connectivity is difficult, takes time, and resources. So, you know, the question is, are they going to come after you if you don't? You don't have everybody connected, but you have some people connected, and you have a timetable and a plan for how to do it? Probably not. I don't think so. The other person you're dealing with in the room is the payer. You got to make sure the payer understands this is where our connectivity is at. And what you're doing with the marketplace is saying to them, come on, give me a hand. Help me get this done. It's going to be a better thing for you. So if we get a contract with you, it's going to encourage more people to join. We're going to have better coverage, et cetera. So that's not an absolute legal protection, but I can tell you that the practical reality is a legal protection. And if you're honestly building a program and it's just slow to get connected, but you're working at it, you have a defense. I mean, you're probably not going to have a problem.
Lynda, did you want to add anything to that?
No, I think John covered it really well. The intent is almost more important than the actual agreements that you have in place. Although obviously you need to have an operating agreement and have an actual structure. But many payers are willing to have conversations before all of the pieces are in place.
Great.
Let me add to that. Lynda said something very important. You can start the conversation before you're done. So we plan to be done connecting everybody in February. Can we start contracting for January and start talking to people? Yes. Again, just be open to what's going on and follow your protocols and your path.
All right, our next question. How do you see the emergency and urgent care medicine specialty participating in these CIN and value-based care programs?
Yeah, so I'll take the first shot at that. So all hospital-based physicians, emergency physicians, radiologists, pathologists even, have a very important role to play across a network as you're developing a group of services that you need for a patient population. At the end of the day, a clinically integrated network, or ACO, is an organization committed to taking care of a population of people who need services across the care continuum. And so all of those physicians, including hospital-based physicians, are essential in caring for those patients. As it relates to emergency room physicians and radiologists, emergency room physicians are key in deciding how and which patients should be admitted to hospitals versus who should be sent to ambulatory care for the appropriate level of care. And radiologists are certainly very important in the diagnostic phases of any person's health care, so that they are also cared for at the right level of service. Keeping patients out of the hospital is an essential part of any risk-bearing contract. When you talk to payers, it's one of the things they want to know what your strategy is, and physicians who are practicing in hospital-based roles are essential in figuring out how to put clinical programs together that really support patients in an ambulatory setting.
I would support everything that Lynda said. But I'll add something. One of the issues we've run into, particularly with ED groups, is your basic national emergency department management company who's managing and employing perhaps the physicians in your ED. And I'm struggling with one right now where there's really no incentive for that company to participate in clinical integration. Notwithstanding that, what we're doing is organizing the physicians in the ED, who just so happen to have really good, strong leadership, And they are going to participate in the metrics, but the management company won't allow any contracting on their behalf. So this is a situation where the management company does its own contracting for the docs. So you're not going to have them in the contracts. I've reached the conclusion that that's going to be okay, because it's so critical to have those doctors. I mean, most of your patients, a lot of your patients come in through the ED, and as Lynda mentioned, we're trying to keep people out of the hospital, and they can be perhaps triaged elsewhere. So the reality here is finding a way to get the docs to participate, whether or not they can participate in contracts. So to be continued.
All right, great. And what is the board's role in helping the organization improve, enhance, or expand clinical integration and value-based care?
John, you want to take the first shot at that question?
Sure. By the board, I'm assuming the board of the CIN. Well, I'll talk about the board of the CIN and the board of the hospital. Start with the board of the hospital. The board of the hospital should be educated about what this program is all about. I think as well, in many cases, we've created employer advisory groups to come in once a quarter or twice a year to take a look at what's going on, to understand it, because a lot of these people they have insurance companies, but they're ASO relationships. So you really need to you want to make sure you're going to have value-based contract with the employer, have them actively involved in the process. So them knowing it and all of that, the board of the CIN usually is the decision maker relative to all aspects of the program, and oversees the quality committee. And the quality committee is going to be one, and you don't need a lot of committees, but you need a quality committee. The quality committee is going to be the one that talks to Dr. Marren and says, or collects the data, reviews the data, validates the data, and then talks to Dr. Marren about what he's doing wrong or what he isn't doing or whatever. So the board oversees all of that process. Again, it's a balance of the board. It's a board-controlled organization, even though the hospital, quote, in my case, or in many cases, owns it. And they have some reserve powers over it, but it really is the board that's driving it. And I really hope I didn't miss the answer. I hope I answered the question.
Anything from you, Lynda?
No, I think John explained it really well. The CIN or ACO board, the other thing that's going to happen with CIN and ACO boards as we move more into risk-based contracts, of course, those boards are going to need to be educated and understand the differences between their current contracts as they enter into risk, in bearing risk, and really understanding what that means for their organization as they're trying to make decisions about how to move forward. Contracting is obviously another area where the board is essential in making decisions and making recommendations to the network.
Great. And is ACO participation a checkbox that equals marketing yourself as a CIN?
No. So,
no.
No. So mutually, we're saying no. ACO is a very specific organization, mandated or brought to fruition under the Accountable Care Act in the Obama administration, what we commonly call the ACA. ACOs are organizations specifically contracted with Centers for Medicare Services to offer services to fee-for-service Medicare patients and participate in CMS's incentive programs for that very specific population. Does not include Medicare Advantage patients or any commercial patients, is a contract between the Accountable Care Organization and Medicare to deliver services in a network for those very specific patients. The payment structures are complicated and getting more and more complicated. As I said earlier in the presentation, the new MSSP rule called Pathways to Success, is Medicare's new structure for moving ACO contracts into risk. Now, in terms of the relationship between an ACO and a clinically integrated network, some clinically integrated networks also have an ACO or an ACO contract with CMS, and under their clinically integrated network have commercial-based contracts or contracts with Medicare Advantage providers or even Medicaid providers. An ACO can be part of a clinically integrated network, but not the other way around.
Yeah, that's correct. And I'll tell another story. There were attorneys who were telling people that if you were a member of an ACO, you were clinically integrated. Well, you might have been clinically integrated for commercial contracting for those physicians for whom there were metrics and being measured, but not for anybody else. So, and then the other laughable thing that I shared with the FTC is attorneys and consultants telling people that there was an antitrust waiver if you're in an ACO. There ain't no antitrust waiver. There's waivers for other things, but it's not antitrust. So we usually build companion organizations, as Lynda said. Maybe you have a crossover quality committee and operations. But we usually have two separate entities for lots of different reasons. And if you need to know all of them, send me an email and I will send you our little PowerPoint on it. But no, they're not. It doesn't qualify you to do broad scale commercial contracting, or Medicare Advantage contracting.
All right. And so what metrics for the independent group managing the ED make sense, and how would that affect compensation normally based on visit volume?
Well, contracted ED providers, it will not impact. I don't think when we end up with this, we finish this deal, we're going to have any impact on their compensation, because the management company is paid in a negotiated rate that has nothing to do with the overall performance. I mean, there's language in the contract that said they won't, they'll follow medical, typical medical procedures, but there's nothing about you're going to do A, B, C, D, and E when presented with A, B, C, and D, and E conditions. So the reality is I don't think it's, go ahead.
John, let me just jump in here. If your emergency department group is not a member of one of the national companies that doesn't allow them to contract, emergency department, a group of emergency physicians can participate in a clinically integrated network and can participate in incentives based on clinical programs that they participate in, assuming that the performance across the clinical program is good. So, for example, if a clinically integrated network decides to have a set of metrics around a particular clinical program that includes emergency room physicians in emergency orthopedics or in readmissions or in CHF, where an emergency room physician has an essential part in making sure that the quality metrics and the care is appropriate for a patient, then emergency physicians can indeed participate in incentive programs in that clinical program.
Yeah, I was only talking about the situation where, because I thought I heard the word separately employed, but the other part about incentives to employed physicians of any kind, of course you're going to include them to the extent you can, but most of the hospitals we've dealt with will, however they compensate physicians, whether it's under their employment agreement or a bonus based on CI participation, you have to look at the MGMA standards and where you fit into that, because most of them have concluded that is just another form of compensation. So you got to look at, if you're near the cap, the high rate of pay for your physicians, you just got to take a look at it.
All right. And what have you seen as the prioritized sequence of infrastructure investments for successful CINs?
Yeah, so in terms of infrastructure expense, there are a couple of things that in areas where you spend very early money in terms of organizational structure, preferred provider contracts. There's a whole group of legal structures that are required when setting up a clinically integrated network or an ACO that requires very early investment. Of course, physician recruitment and contract management also requires early investment. But the big investments early in setting up a CIN are really in the question of data collection, quality metrics development, and performance metrics against contracts. And that's really where most organizations spend their first big dollars in terms of infrastructure. Obviously, you need some people to get all of this work done. But the major expenses are generally in staff and in technology.
Anything from you, John?
Nope, I agree. Technology is the heavy lift. Obviously, you need staff and the like. And I would tell you this: hospitals can finance these for a few years, but then the organization has to start paying its bills, especially exempts. And one of the things you need to do as a health system who's doing one of these now or starting one is to begin to quantify the benefits to the organization. Fewer uncompensated readmissions, better, reduced costs through the benefit plan. The benefit plan should have a contract with the CIN, better throughput, anything you can find that demonstrates the value and quantifies the value. So keep track on day, have some goals and a vision for how you're going to track what the benefits are to the health system, because the health system is financing it. And then after a while, most valuation people will tell you that it's really necessary for the dollars that come in to start paying for expenses. I don't know that hospitals get a dividend from the shared savings payment because it's mostly physician activity or completely physician activity. And I've seen fair market valuations as high as you got $6 million that comes in shared savings and care management fees. I've seen valuations that say you can pay 100% to the physicians. Now, I haven't seen people actually pay 100%, but 85, 90%, yes. But at the hospital level, day one, start putting some goals together for how the CIN is going to help you.
And how do you take the value-based delivery models in the CIN, ACO, and scale that across the organization, even if there is a risk of losing money in fee-for-service?
So scaling your CIN or ACO is obviously an essential part of making the strategy work for your institution, whether your institution is a large hospital system or an independent physician group. Most organizations review and understand the potential contracts available and begin to scale their organization based on the performance necessary in a particular contract or a group of contracts. Some organizations begin with their own employees and their beneficiaries, develop some goals based on the data that you've gotten about how that your employee benefit structure is performing, and then scale across program. So if you are in an area of the country where you have a particular problem in your clinical spend in asthma, you're going to start developing a clinical program across the network through acute care and ambulatory and post-acute care to deal with that clinical problem. Very much like you do, or some organizations have done in service line delivery. One of the things that John and I also have a great interest in is really understanding how your clinical service line can work with your clinically integrated network and expand across your system to improve quality and cost management for a beneficiary population.
Good point, really good point. And I think we're going to have a webinar later that talks about service line integration, bringing hospitals together and completely integrating their service lines as opposed to merging the hospitals together, and to the point where it allows you to collectively negotiate for those service lines. So a lot of hospitals are interested in this because there's a big FTC pushback on hospital mergers, and they've been very successful at stopping them. And it's also a way of protecting my referrals. If I'm a quaternary hospital, I want to have service line integration with my rural hospitals from where communities that I get business from. So we'll talk about that more some other time.
And for data or metric gathering across a physician-based CAN, is gathering the CMS ACO measures and monitoring of such acceptable?
Yes. So you can use any group of measures that you think is going to improve the quality and cost curve for your particular patient population. Many CINs begin with some group of measures that are also ACO or HEDIS measures in their clinical integration network. It's sort of the easiest. It's an easy place to start because those measures are available in the population. Physicians understand some of them in their MIPS or MACRA measures that they've been doing for a couple of years. And many of them also are really useful in moving a clinical program forward to improve quality and reduce cost. Of course, you can also set specific measures for your own organization, and we encourage people to do that all the time as you're looking at a particular beneficiary population. For example, if you're in a pediatric population, you want to have very specific measures that you are looking at to make sure that your population is actually moving forward in the improvement, on the improvement curve. So absolutely, to begin with, national publicized measures are a good place to start, and then thinking about specific measures for your population ultimately is where you want to go.
Agreed.
All right, and one last question. How do you use CINs for fee-for-service negotiations?
How do you use, well, that's what it is for. I mean, I'll just jump in, and then I've got a hard stop in about a minute, but what we do and what Lumina does is really say, look, here's our metrics, here's our way of measuring quality, and we're looking at maybe a 40% reduction in cost overall, and going to payers and employers and really talking through that. It may be that these payers already have contracts with the doctors individually, so you're just building something on top of it that says it's value-based. Lynda, why don't you go ahead, too?
Yeah, so sure. Many organizations in clinical integration begin with a fee-for-service contract and add on to it upside-only incentive program. The value-based contracting portion of that contract is really where your value comes in from your clinical integration network. There are organizations who have moved their entire contracting arm into their clinical integration, into their CIN, so that the CIN negotiates on behalf of the large group on both fee-for-service and value-based contracts, with the goal of moving all of those contracts into value-based over time. But generally, fee-for-service contracts are the floor from which a CIN grows.
Great. Next slide, please. I want to thank all of you for attending and all for all these great questions. We really appreciate it. This is contact information for Lynda and John. If you wish to email or call them directly, you can do so. And also, please check out our website at luminahp.com. You can also follow us on Twitter at luminahp. You can follow our company page on LinkedIn, and also check out our YouTube channel at youtube.com/Lumina Health Partners. Thank you again for joining us. We hope you got a lot of value out of this webinar. We look forward to seeing you on future webinars. Have a good afternoon.
Thanks so much, everybody.